everyone for attending. Please excuse me, I'm recovering from a cold, so my voice is a little bit hoarse. And please let me know if you can't hear me at any point. My presentation today is on vaginal fold prolapse. I'm trying to move to my next slide. Right. So the summary of my presentation is that I'll do case presentations. I've got 2 in detail and 1 other one that has a pointer that I wanted to ask about. I'll then give a summary of the anatomy of the supports of the pelvis, and then risk factors for fold prolapse, and then a discussion which will mainly center on the surgical options for management of fold prolapse. My first case is Mrs. A.M., a 77-year-old Caucasian widow who's a retired teacher. She was a referral from her general practitioner. Her presenting complaints were a painless, fleshy vaginal mass, which she had had for some years. She also had on and off incomplete bladder emptying, and occasional urinary incontinence, but she said that the incontinence isn't a big factor for her. So this mass, she finally then came through to see me because it was growing and she was now noticing it more frequently, because before she would notice it rarely, but now it was more noticeable for her and giving her slight discomfort when she was sitting. On systemic review, she had no dysuria, no fever or malaise. She had normal regular bowel motions with no constipation. She was a mobile, generally fit patient who just had a brace on her right knee. She was being managed as arthritis by her general practitioner with NSAID use as necessary. Other systems were unremarkable. Her gynae and obstetric history, she was a para 2, both normal vaginal deliveries. The weights were 3.5 and 4 kilograms. Notably, she had 1 macrosomic baby. There were difficult deliveries, but she had no instrumental deliveries. She doesn't remember the duration of the second stage of labor. She had no STI treatment. She had a poor recollection of menarche and contraceptive history. She vaguely remembers using the pill and the diaphragm at different stages of her reproductive life. She had a hysterectomy done in 2007 for benign abnormal uterine bleeding. She says that her uterus was sent to the lab and she was told that everything was normal after the surgery. The history continued. She was a well-controlled hypertensive on losartan at 100 milligrams orally daily. She had no history of any other surgeries. She had no known allergies. She was a non-smoker and an occasional light drinker. She lived alone in an apartment, in a small apartment in Harare. On examination, she was a well-looking patient, mildly high systolic blood pressure, but for her age, it's actually not bad. Her weight was 72 kilograms and she was of average height. She wasn't obviously of a high BMI. On abdominal examination, there were no masses felt. I noted a fine and still scar from her hysterectomy, and there was no abdominal tenderness. On pelvic examination, she had apical and anterior compartment prolapse, which was noted more than 1 centimeter beyond the vaginal orifice. So I staged a stage 3 prolapse using the simplified POP-Q staging. There was slight erythema of the leading part, and the tissues were apparently thin and hypoestrogenic. The posterior compartment, though, looked intact. So I discussed the findings with the patient, and we discussed conservative management, surgery, and supportive measures. For this patient, she opted for a pessary, mainly for financial reasons. So I fitted her with a size 7 ring pessary and gave her instructions for Kegel exercises, and she's to use estrogen gel twice a week. It's been about a month since we inserted the pessary. She came for review at 2 weeks and she was happy and comfortable. So for now, this patient is using the vaginal pessary. The next patient is Mrs. DM. She's a 56-year-old Black patient who's married. She's a retail business owner. She was referred to me from a fellow obstetrician complaining of a mass per vagina, sorry for my typos, for a few months. She has children in Canada. So she first noticed this mass while she was in Canada and she was seen by doctors there. She says she had blood tests and imaging done. And all she was offered was some estrogen cream to insert a few times a week. But since she started using the estrogen cream, the mass continued to recur and the bulge became more and more noticeable for her. She had no associated bowel or urinary symptoms. Her menarche was at about 16 years of age. She had regular periods. She used the pill for contraception as far as she can remember. She had no treatment for STIs. She was a para 4. Notably, she had big babies ranging from size to 3.5 to 4.5 kilograms. And she had a vacuum for her largest baby who was 4.5 kgs. She had a hysterectomy done for fibroid uterus, which was an abdominal hysterectomy. She couldn't remember which year it was done though. She says that she was told that everything was normal after the histology was sent to the lab. On medical and surgical history, she was diabetic on metformin at 1 gram slow release daily, well controlled, hypertensive on amlodipine 10 milligrams daily, also well controlled. And she had been on this treatment for more than 10 years. She was a non-smoker. She was still sexually active and she's a non-drinker. On examination, she was a very well-looking patient. Her observations were normal. Her weight was 76 kilos and she's on the tall side. She didn't obviously have a high BMI. She had an abdominal surgical scar noted, which was subumbilical. On examination of her perineum, she had anterior and apical prolapse noted. The leading end, I made a mistake there. The leading end was actually the anterior part, and it was at the vaginal introitus. And I staged a stage 2 prolapse. The tissues, there was no excoriation, and the tissues were relatively well estrogenized tissues. And she was initially very averse to surgery. And what we did initially was that we tried multiple pessaries going between different sizes. But the smaller one would fall out and then the next size would give her discomfort and excoriation. So she's now decided that she'd want surgical management also because in the course of the last 2-3 months, the bulge is more apparent to her and she's not happy with that. So I'll move on to the anatomy of the supports of the uterus, but maybe first, are there any contributions before I move on to that? May I go on, moderator?
Sorry, Taku.
Yeah.
I just wanted you to clarify for the first patient who had a bit of incontinence with the whole prolapse, what kind of incontinence it was? Was it urge? Was it stress? Urinary incontinence?
It was actually very difficult to get the history of what kind of incontinence it was because the incontinence was something that I got on further asking her. What she said was that she just found herself to be wet sometimes. She wasn't very aware of any triggers or whether it was stress incontinence, but she said that it was also not a common occurrence. So I didn't actually manage to establish what kind of incontinence it was. And when I examined her also on straining, she actually didn't leak on the day that she came.
Oh, okay. Thank you.
Any other questions?
Thank you, Tago, for the presentation. Mine is just in terms of the medical management. I have prescribed primary gel for a number of patients, and they've been telling me they can't get primary in jail, locally or even in SA. How were your patients accessing this?
Thanks for the question. On the market, Premarin is a bit difficult to find, but Onco Pharmacy at Newlands, I spoke to the pharmacist yesterday. She has Premarin cream. She's also got some Femi something pessaries that she's got. And Femigel, I'm not sure. Some of the patients were finding Femigel from other pharmacies, but Premarin specifically has been very hard to find. So what I've been finding more easily on the market is Femigel. But certainly Ashbrittle Pharmacy and the pharmacy at Newlands has estrogen.
All right. I have one patient who went and was given Femigel as an alternative, but the insert is specifically written, do not use inside the vagina. So she was really worried, and then asked a friend to get something from SA, couldn't get them as well. So it would be interesting if we could direct them to the pharmacy I've just indicated. Thank you for that.
Thank you. I'll WhatsApp you the details. Right,
Thank
so I'm going to move on to the next section of my presentation, which is the anatomy of the supports of the uterus. The supports of the uterus are divided into 3 levels of support: level 1, level 2, and level 3. The level 1 is the uterosacral cardinal ligament complex, which originates in the cervix and the upper vagina and inserts on the pelvic sidewall and the sacrum. Most of it actually inserts onto the coccygeus muscle and the sacrospinous ligament, according to MRIs. It maintains the vaginal length and keeps the vaginal axis close to horizontal when a woman is standing. Level 2 support is actually continuous with level 1. So when we describe these things anatomically, we distinguish them into separate things, but they actually are in continuum in the actual patient. So the anterior vaginal wall is suspended laterally to the white line, which is also known as the arcus tendinous fascia pelvis, ATFP. The ATFP originates in the ischial spine, and it inserts on the inferior aspect of the symphysis pubis. The detachment of this lateral vaginal support, it gives paravaginal defects and anterior prolapse. The posterior vaginal wall is attached to the pelvic side wall. The distal half fuses with the aponeurosis of the levator ani. Sorry, how do I go back? I'm not sure how to go back on my slides. Okay, I found it. Right, so I'd spoken about level 2 support. Moving on to level 3 support. The anterior vagina actually fuses anteriorly with the urethra, and then posteriorly it fuses with the perineal body. So disruption of the anterior part would give urethral hypermobility and stress incontinence. And then posteriorly, it would give distal rectocils and perineal descent. So the risk factors for apical prolapse are prior hysterectomy, and particularly if at the point of hysterectomy, there was the presence of prolapse. Also vaginal delivery, which is evident. Okay, that first risk factor is there for all my patients, obviously, because it's the fault. And then vaginal delivery, they all had vaginal deliveries, particularly difficult vaginal deliveries with big babies. The other risk factors for vault prolapse are prior surgery for pelvic organ prolapse or incontinence. So it would be a recurrence of pelvic organ prolapse, or if there was surgery done previously for incontinence. And in general, post-surgical recurrence is higher for patients who smoke, patients who have a high BMI, and if there is a greater element of anterior prolapse at the time of the surgery. So I'll go into the surgical options now. The gold standard traditionally for apical prolapse is abdominal sacrocolpopexy. However, with the availability of keyhole surgery, laparoscopic and robotic surgery is also available. So what happens is that the vault would be attached to the anterior longitudinal sacral ligament at the sacral promontory. This surgery gives better restoration of anatomy. So that's on assessment. If you were to do an MRI or check your patient, the anatomy is restored better when the approach is abdominal, whether it's laparoscopic or robotic. The vaginal options for surgery would be sacrospinous ligament fixation, uterosacral ligament suspension, and for those whose uterosacral ligaments may be difficult to palpate, the vault can be sutured to the iliococcygeal fascia instead. Another option is colpoclesis for those patients who are no longer sexually active. So the abdominal approach may be preferred if the patient has a high risk of recurrence. And the patients who have a high risk of recurrence are patients who are younger, particularly younger than 65, but in general, those who are still active. And then patients who are obese, patients with more advanced prolapse, patients with the previously failed repair, and patients who are likely to still exert themselves with heavy lifting. But the abdominal approach, as compared to the vaginal approach, gives longer operating times, has a longer recovery time, and is a higher cost as well. So there are some benefits of approaching the surgery vaginally. Data shows that for older women, particularly over the age of 65, they had a higher readmission rate after the open approach, so double the readmission rate of younger women. They also had more GI complications, as much as 5 times more. They had more surgical site infections. And also the vaginal approach using native tissue would avoid mesh complications, which is of course very topical at this point. And also in general, it's important to know that mesh complications are higher for patients who are immunosuppressed and patients who are smokers. And also if you have a patient for whom estrogen therapy may be contraindicated. Also with the vaginal approach, it's also easier to address rectocele and urethroceles that might be accompanying the vault prolapse. But there's an argument that when you address the apical prolapse, it also automatically will address any significant anterior or posterior prolapse. So what's similar with the two approaches? So you can look at it as the anatomical correction. The anatomical correction tends to be better with the abdominal approach, but this patient's symptomatic success is actually similar. This is from meta-analysis. Reoperation rates are also, there's a tendency towards reoperation for patients who are approached vaginally, but the meta-analysis actually didn't show any statistical significance between the two. The complication rates overall also looked to be similar. I'll allow time for discussion now.
Thank you so much for the presentation, Doc. Just on the last slide, when you say recurrence rate, are these recurrence of a vault after we repair the vault?
Yes, this is recurrence of the vault prolapse after you've operated, after you've resuspended.
So what will be the next step after that?
You can repeat the surgery, you can go back to conservative management.
Okay.
Depends on what the patient prefers. I don't know if there's another option besides that.
All right. So I want to I want to come to the cases of vote prolapse after a hysterectomy. Is there any higher risk of having a vote prolapse in a patient who had vagina open or laparoscopic hysterectomy? Is there any difference in your reading? Is there any difference in the risk of prolapse having approached the initial surgery with any of those options?
Thanks for the question. I didn't find any difference in terms of the initial approach of the surgery, just the coexistence of anterior prolapse at the first surgery. I'm not sure if anyone else knows any difference.
Okay. And then the issue of macrocaldoplasty. In terms of the patients that you presented in your reports, had any of those patients had an attempt to prevent the prolapse by fixing the vault in the initial operation?
Unfortunately, they were not aware of whether anything was done at the point of the hysterectomy, and the notes were not available. So the information was not available to me.
All right, thank you for that.
I think Dr. Jackson maybe can't, I don't know why he can't chat, but he has put a question that what about laparoscopic pectopexy?
I didn't look at that. I didn't look at that separately. The data that seemed to be available was just the comparison of the sacrocolpopexy and the vaginal options. Perhaps you can educate us on the pectopexy.
Right. What I think, hello. Right. What I think is important is that the laparoscopic and abdominal routes, they are actually similar and comparable. And a reason being that the correction is almost exactly the same, except that you are only, the other one, you are just doing it laparoscopic, and the other one, you are doing it open. But otherwise, the results are exactly the same. And the literature and even the recommendations of RCOG, they actually say they are comparable, except that the laparoscopic route will give you a better cosmetic outcome.
Thank you for that, Dr. Shaw. When you do the pectopexy, what are you attaching to what exactly? Excuse my ignorance.
Good evening, everyone. Basically, I just saw this procedure being done last week by professor from Jovic, where patient that post-hysterectomy with anterior wall and apical prolapse. And what they did, they attached the mesh to the iliopectineal ligament, left and right, and reflected the bladder down, and attached the central mesh to the vagina and closed the peritoneum. So you attached, it's like, I don't know how to describe the mesh, but the left iliopectineal line, right iliopectineal line, you attach mesh there. After you have opened the peritoneum and reflect the bladder down, and the central mesh is slightly bigger, you attach it to the vagina, then you close the peritoneum. That's what they did.
Okay, thank you. I understand.
There are two questions from Chipo, and I think very pertinent questions. Is it ethical to speak to the surgeon who operated to ask whether any suspension procedure was done initially? Would it make a difference? What sort of procedure can we do to prevent this vault prolapse? Perhaps you had a slide that I missed. That's two questions from Chipo, very pertinent questions. Do you have answers, Taku?
Maybe let me start with what we can do to prevent prolapse. I think the commonest is to tie together your sutures that are on the uterosacral ligament complex, and you plicate them at the point of the surgery. I know there are more advanced ways to suspend, but that's the way of suspension that I'm familiar with. I'd be open to the floor to telling us other ways of suspending the vault before we address the part about speaking to the previous surgeon.
Yeah, so that's the macrocaudoplasty, where you suspend the apex, the vault to the uterosacral cardinal ligament complex. That helps with prevention of vault prolapse. And for most patients, it works, but for others, it may fail. But that's the most common mode of preventing vault prolapse.
Sorry, Dr. Nyakura.
Hello?
The macrocaudoplasty, is it at the time of vagina or total abdominal? I don't know whether you are.
At both operations, you can do the macrocaudoplasty.
Oh,
You
okay.
can do it at vagina, or you can also do it at open surgery.
Okay.
And even
Thank you.
laparoscopy as well.
Dr. Murudu, are you speaking?
No, I wasn't speaking. Can you hear me?
Your mic is on, yes.
Oh, sorry, I didn't notice. I'm actually driving, so
Oh,
I wasn't speaking. I didn't notice. Sorry.
So shall we move
So
on to the question
then-
about speaking to the previous surgeon, or?
Yes, I think, Taku, you must clarify what are the supports of the vault, not supports of the uterus, but supports of the vault. After you have done the hysterectomy, what are the supports of the vault?
I thought the uterosacral cardinal ligament would be what would be supporting the vault.
Okay, that's one.
And
That's
then below
one.
that, it would be the levator ani.
Okay. And you also, I think you also do the Fothergill suspension as well.
What's that, Doc? Please clarify.
The Fothergill suspension, when you see, the thing is you need to reconstruct after you have done, you have removed your uterus. You need to put the vault as close to where the uterus was, to the original supports. So the sacrouterine ligaments, you must attach them to the vault. So when you actually, the modified Fothergill is where you take the sacrouterine transverse cervical ligament, you actually bring it all together, and you suture that together to give it one complex. And then that is one. And then you make sure that the Donenfeld, the Donenfeld fascia, or the anterior vaginal, what do you call it? The rectogenital fascia, you bring that together as well. I don't know whether you understand that part. And then that's how you build the supports to the vault only. And then, because remember, the vault no longer depends on the flexion or version of the uterus. It no longer relies on that as a support. I don't know
Okay,
whether I'm.
Well,
Yeah.
I vaguely understand it, but I think I need to see it in practice. Is that the
Okay.
point at which you sort of recreate the cervix from the way that you did the other
Yes,
surgeries when we operated together?
Precisely. That's exactly how you sort of create a neo cervix. And that's the whole process. When you are creating that neo cervix, that's the whole process of actually bringing everything together so that you create a support. And that also, you know, the plication that you do on the vault, it actually makes sure that you are not going to have the central prolapse like the enteroceles. You won't actually get, because you bring all that together.
Okay, thank you. I understand.
Then
Shall
the
we move
question
to this?
about, yeah, next, the other question.
The other question was, is there any point in speaking to the previous
Is it
surgeon?
is it ethical?
Ethical? Is it necessary? I doubt that it would make a difference in how you would go forward. But I don't know if others have other ideas.
I really think, yeah, this one is very important actually. It actually has an impact in terms of how we're going to progress. In fact, the referral doctor should be able to give you that information without you having to ask for it. This is a patient who has gone back to their doctor because they had a prolapse. Now, if I was the one who was going to be referring this patient to someone who's able to do the procedure in terms of having to repair the prolapse, I should be in a position to divulge all the information in terms of what transpired in the operation, because it has a bearing on what then needs to be done. So if this information is lacking, I don't think there's any problem in the doctor who's receiving the patient to inquire on the referring doctor where there are gaps in terms of the history or in terms of what was found or done during the procedure. So I think in terms of ethics, there is no contraindication in terms of getting information, because after all, this is trying to help the patient. So there shouldn't be any issues to that.
No, I think I understand your point of view, but I've got quite a few patients with prolapse post-surgery, and you'll find that most of the time the surgery was done many years ago, more than 10 years ago. So I'm yet to find a patient whose surgeon is able to give those details or is available to give those details, because the one that I said referred by a fellow obstetrician, it's not because it was their surgery. It's actually just because they know that I have a special interest in urogyne, not because it was their operation. So half of them have forgotten who did the hysterectomy, or whoever did the hysterectomies has already retired, or the information is not there in the patient's notes at all.
Okay.
I think it's important that there is nothing unethical with asking for information from a colleague. And in fact, if the colleague is still alive or has not retired, even if he's retired and is able to have the information, there should be no problems at all in discussing cases with a colleague. Chipo, are you answered?
Yes, I am. I think my Wi-Fi was also in and out. Yes, I am answered. I think, well, my thought is it's probably better to speak to the original surgeon, because then what tends to happen in the market is you hear it as a story that I'm now repairing so-and-so's vault prolapse, yet it's probably more professional for us to confront, well, not so much confront each other, but approach each other and just, yeah, I don't know, troubleshoot, but I'm still very junior in this career.
And I have a question for you, Taku, again. You said the gold standard is the abdominal approach to sacrocolpopexy, isn't it? And why is the vaginal route not the gold standard?
I'm not sure if I can answer that.
Yeah, I think yeah, you must remember I think it's to do with if you look at the complication rates and the failure rates, vaginal route has got a failure rate of about 20, I think you quoted 17%, but the literature, I think, has got something like 20%, compared to the abdominal, which is way lower than that. But for some reason, statistics say there isn't any difference between 10 and 20%. But that is the main reason why they say this that 20% failure rate or recurrence rate is the reason why the vaginal route is not actually the gold standard. But the procedure can still be performed vaginally as well as abdominally. And your patients, the patients for vaginal route, those patients, you remember most of these patients are frail and they are not very, some of them might not even be fit for general anesthesia. Then the vaginal route becomes much more convenient for those patients. And their hospital stay is much less when you do it vaginally than abdominally.
Well noted. Ngwaru, I think you have a question.
Hi, Taku. Thanks for the presentation. I don't know if you can hear me.
Yes,
Hello?
we can hear you.
So my question, thanks for the wonderful presentation. My question is the native tissue repair versus the mesh repair. I don't know if you looked into that, whether which one is more superior than the other.
So mesh repair in general is supposed to give less of a recurrence rate, but the problem is the mesh complications. So that's why people are steering away from using mesh. That's the information that I got from my reading.
Do you have an I was saying, do you have an alternate view, Dr. Ngwaru?
No, I think mesh they give better results than native tissue. So I think the argument has been, if you're using native tissue that has already shown that there is a problem with them being laxy causing a prolapse, why then should you continue using them? Because there's already something that is wrong with those tissue. I don't know, but I think there's another school of thought. I think there's one school of thought that thinks like that.
So I think with using mesh, what's important now is the preoperative counseling and also identifying those who are at higher risk of mesh erosion. So the preoperative counseling is what's important. And then if the patient consents to a mesh, then you can put a mesh in. And then if they don't consent because of the risk of mesh erosion and mesh complications, then you then use native tissue with them aware that they have a higher risk of recurrence if you're using native tissue. So the appropriate counseling is what's necessary.
And then my other, oh, sorry. So you can go ahead.
Dr. Ngwaru, you can go ahead.
No, I thought you were still talking about, because I wanted to raise a completely different issue altogether. So I allowed you to go ahead.
No, that's fine. I have nothing to say.
Okay. So my other question was the use of the POPQ classification with regard to the initial examination and the classification of these products, whether you managed to look into that, because I think that's what has been agreed to use so that people can talk a universal language.
Right. So I actually have a slide on the POPQ, if I can make it come up. So the thing about the POPQ is that it's a little bit complicated, but this is one of the slides that describes the POPQ. So for simplification, there are other classifications that you can use that just make your job easier. But for the POPQ, you then assign these points, and then you use the stick with the centimeters to assign numbers to all of these points. I find it very hard to explain the POPQ myself. So that's why I then included the next slide, which is the alternatives that you can use, which is the Baden-Walker half and half system, and then the simplified POPQ. So yes, for the sake of comparing data and so on, ideally we should use the full POPQ system. But in a practical sense, I find the POPQ confusing myself. So I use either the simplified POPQ or the Baden-Walker half and half system, which is what's on the slide now.
So for your two patients, how are you going to, what is going to be on the consent forms?
Right, so the first patient is happy with her pessary, so she'll continue with the pessary for now. For the second patient, do you mean what procedure am I putting on her?
Yes, what
consent
procedure?
form?
Yes.
Right, so it would be the, let me go back to my surgical options. So it would be, I was going to discuss with you, Dr. Shava, to be honest. My assumption is that we are going to do either the sacrospinous ligament fixation or the uterosacral ligament suspension.
Okay. Yeah, what I normally do in practice is I actually get consent for anterior posterior repair and suspension. And because the reason being, you invariably, even if you cannot see a need for a posterior repair, at the time of surgery, you may actually find it necessary. So it's always better to get consent for both of them so that you know that even if you have to leave one, that will be fine, depending on the assessment that you do at the time of operation. So
Okay, I get your point.
Don't get a consent where you say vault suspension or sacrocolpopexy, and then you end up not even doing that when you realize that no, it was not an enterocele, it was probably a rectocele or it was a cystocele.
Okay, I understand.
Yeah.
I have a question for the floor. I have a third patient who was sent also from her GP. And on examination, she has a a rectocele. She's an elderly Caucasian lady. She has a rectocele, which she is not conscious of. But her reason for coming through is that she has stool incontinence, where she can be going through her day at the shops, and then she'll see a small amount of stool coming out. But when I examined her also, the tone of her rectal sphincter felt like good tone. So what I wanted to ask was, is it possible that this rectocele, where the stool is accumulating, is the reason why she then will leak stool sometimes? Does anyone have any ideas? And will repair of the rectocele help with her leakage of stool?
Dr. Ngwaru should answer that one. Ngwaru or Felix?
Hi, Dr. Shah. I think it's to do with the anal sphincter complex that needs to be assessed, and maybe that's the one that needs to be fixed. In terms of repair of the rectocele, I thought you were going to dive into the controversy of that into more detail, especially in terms of the development of that rectal vaginal septum, because I think there is new literature which seem to suggest that there is nothing like that. So there isn't anything really to repair there. And most people, they tend to seem to say, if you repair the apical, you automatically repair the posterior prolapse. So I stand to be corrected, but I think that sphincter, the anal sphincter complex, needs to be sorted out. But I think that's what I think. This patient, she's a para. How many she does she have?
If I remember well, she's a para 2 or 3. But the sphincter feels, you know what I mean when you examine a sphincter? She's got pretty good tone. So that's why her history wasn't making that much sense to me. And she didn't actually have particularly large babies in her history.
Okay, any history of tears?
Not as far as she remembers, no.
Yeah.
And Felix?
Yes, Dr. Shawa.
Yes,
I agree with Dr. Ngwaru. I think the problem is with the sphincter. So since clinically she doesn't have, she feels like the sphincter is okay. I think that would probably do a more formal testing of the sphincter. So I don't know whether that would help, because I don't think that it's the problem is with the rectocele, but with the sphincter. So maybe a formal testing would assist. I don't know.
Dr. Marudu?
Can I? Yeah, because I think what usually happens with the rectocele is that patients would tend to have incomplete evacuation of the rectum. So with incomplete evacuation of the rectum, that could then lead to the rectum always feeling fuller and should always have stools in there. But I think also it might also be related to some sphincter incompetence at the same time. So she could be having two pathologies. In terms of the repair, as Dr. Kwari has said, that fixing the apical might fix it, but as well, I think it's worth going for the rectocele as well, because that would then mitigate against incomplete evacuation, and therefore she should be able to void completely and not have stools remaining in the rectum that would possibly cause the rectum to always feel fuller, and even on passing flatus, she might evacuate some of the feces that are left.
Taku, are you answered?
Not entirely. I tend to agree with, sorry, I didn't see who was talking just now. I would tend to agree that if she has residual stool in her rectum, there's a possibility that, like what he's saying, when she passes flatus, she then passes that residual stool. So repairing her rectocele may assist. But I think what I've gotten from the other contributions is that she needs a more formal assessment of her sphincter, which I'm going to try and organize before proceeding with repair of the rectocele, so that we see if anything is picked up on a more formal assessment of a sphincter. And what does that mean when you say more formal assessment? Please elaborate.
I think Gwaru wants to come back. Dr. Gwaru?
Yes, sure. Yes, sure. So it's my belief that people have stool in the rectum all the time. It's not like they just come when you're about to pass through, but it's the ability of the sphincter to be able to release it when you voluntarily want to release them. That is a problem in this case. So I still stand with that the sphincter, the anal sphincter complex, in this case is having a problem, and it needs to be assessed. There's some tests that you can do to actually check for the for that tone of the anal sphincter tone, which because I don't do them every day, I need to really check and maybe come back to you with a more correct answer. But I think there are some tests that you need to do to see how that sphincter is working.
Dr. Taku?
Yes.
I think the simplest one would be to just do an endo-anal ultrasound, so that you can actually look at the sphincters themselves. I'm not sure whether we can do a manometry locally. I'm not sure, but I think locally we should be able to do an endo-anal ultrasound.
Okay, thank you. Maybe I'll talk to the radiologist about that.
Oh, so I wanted to ask, in all these patients, is there a role of physiotherapy?
For all of them, what I discussed with them was skeletal exercises and how to do them. And to just interrupt the flow of urine so that they get the movement that they should be doing right. Yeah, that's what I spoke to them about. I didn't send them formally to physiotherapists.
And when you started, you said she has got a rectocele that she's not aware of. What did you mean?
So this patient, she went into her GP complaining of occasional leaking of stool. And then when the GP examined her, that's when she noticed that there was a rectocele on examination. And then also she examined the sphincter and also thought that the sphincter felt like it was of good tone. So assigned the symptoms possibly to the rectocele. So that's why I'm saying she was unaware of it. She doesn't have a feeling of a bulge, a vaginal bulge or anything.
Felix, you have got your hand up again.
Dr. Taku, is there any particular reason why pelvic floor muscle exercise was not part of your treatment option?
It was part of my treatment option.
Oh, okay. Sorry,
yes,
I missed that.
For both of them. I universally tell them to do pelvic floor muscle exercises.
Okay, Thank you.
as the most conservative approach. So the most conservative approach I offer is pelvic floor muscle exercises combined with estrogen cream before we even add on a pessary. But then it also depends with the degree of prolapse, because if it's anything stage 2 or greater, then that alone may not work, but particularly stage 3 or 4, that may not work. But for the earlier, maybe incidental findings, then the pelvic floor muscle exercises and the estrogen cream is actually my starting point.
Okay, so you are saying that there's evidence to use of estrogen cream for prolapse?
Not entirely, but I found that when I examined the patient, most of them they have hypoestrogenic tissues. So I offer them estrogen cream. I'm not sure to say there's evidence, but when the tissues are thin, I do offer estrogen cream in addition to the Kegel exercises.
Okay, thank you.
I think the question that was asked earlier was, is there a role for physiotherapy? And the answer there should be yes, because some of the data that came out was that patients tend to do better with pelvic floor exercises that are supervised by either a physiotherapist or a urogynae nurse than those that do them themselves. So the physiotherapist, the pelvic floor exercises that are done by physiotherapists have shown better results as compared to what you generally tell patients to do at home. So there is a role for physiotherapy, just to add.
Okay, thank you for that.
Chipo wants to know the difference between pelvic floor muscles exercises and Kegel exercises, or are they the same?
As far as I know, they're the same, but it's not the same. Pilates is a whole different thing from just Kegel exercises, as far as I know. But in general, pelvic floor muscle exercises and Kegels, they're used interchangeably. So maybe it depends on what your understanding of what you're telling the patient is.
Right, I think we are way past our time, and I think this discussion can go on and on and on. And I think, remember, the purpose of these discussions is to stimulate more discussions. And I think we should probably call it a day, unless if there is something very burning. I think, Taku, we can close the meeting.
Thank you for your attention and your contributions, everyone. Have a pleasant night.
Thank you.
Thank you.
Thank you.
Thank you.